So if you keep to the 20 minutes.
Okay, yeah. Where is this one? Okay. Okay, so this is a completely different subject from what I told you before. But again, it's related to nanotechnology. It's collaboration with tribologists. Tribology is a field, the science of friction, actually. So this guy is really dealing with machines and friction. And actually, we started to collaborate on this project a few years ago. And the reasons that it was done is because there is a very large problem that people at my age and others are very well aware of it. And this is cartilage destruction due to wear, which I wrote with a typo here. Due to increased friction, the wear is become faster. This leads to pain and inflammation, and to a disease that's called osteoarthritis. That is probably the most frequent disease in the Western world, and I think quite large percentage, 2% of the people in the world suffer from this. And if we look carefully at the disease, it's really very, in a very simple way. We can see here, this is a normal knee, a normal joint. And we can see these are the bones, there are cartilage here. And this cartilage actually helps the smooth motion. It's almost a frictionless. It's amazing how efficient lubricants we have here in the synovial fluid that really protect the cartilage. And for many reasons, it starts going wrong. We start having initial stages of damages. Cartilage start to be distracted. We expose some brain. We get a bad friction. This will lead later to inflammation, complete destruction of the cartilage. And people start having really severe pain. It becomes very, very difficult to move and so on. It's not only to the knees. It's happening in the fingers and many other places. So it's one of the diseases or pathological situations that there are no definite drug to it. So you can start with something like painkiller that will help the pain but really not do anything to the disease itself. You can start with corticosteroids that really will help, again, in reducing the inflammation. In case it is done, it's oral, but has quite a lot of side effects. Or you can go to a more recent drug. This is the hyaluronic acid that is now quite increasing in sales. And every one of them is doing differently. You can see hyaluronic acid, people believe, and there are no really strong proof for it, but people believe that it works on the viscosity level. It's obvious today that it's not a lubricant, what people thought in the beginning. We came with the idea based on some previous data of other people that lipids that are actually present in the synovial fluid and actually their level go down dramatically in case of osteoarthritis may act as a very good lubricant, and the mechanism is a boundary lubrication. So this actually what we want to develop is a liposomal preparation that can do this effect, that can reduce friction and reduce the wear of the cartilage. Well, this just tells you how many people suffer and so on. It's a really serious disease. Let's leave it. And this already I told you, in case that it goes to extreme, you have to do a surgery, a hip replacement, and so on. But you have all other alternatives before, started with OTC and going throughout all the drugs that we discussed. Now, there are a lot of studies were done with hyaluronic acid, and very recently 5 very elaborate meta-analyses that really contain a lot of study were done. All were done double-blinded studies, and the bottom line that the system helps, but it's not very efficient, and it's definitely not something that will cure the disease. I have to say that hyaluronic acid was approved as a medical device because it doesn't interact chemically with the cartilage, neither with the bone, and it really have a physical effect. That was the claim, as something that changed the viscosity. It was accepted by the FDA and by the EMEA as a medical device, and that's the way it's going. Now there are about 6, 7 companies that are producing it, and the total market in the world is coming close to $1 billion, which is quite big. And if it will be more efficacious, it will be much larger. This chart shows you this number. These are the different preparations. Genzyme was the first. Now there are many more companies, and there are companies that actually are not included in the list. So we decided to really try to see the phospholipid, and since we believe that liposomes are the best way to deliver phospholipid, we tried to use it. But before us, an Australian MD PhD by the name of Hills, he died unfortunately 3 years ago. He decided to take a phospholipid called dipalmitoyl phosphatidylcholine, I'll show you the lipid later, and put it in a propylene glycol, inject it to people after doing all the study first in small animals, then in horses, just safety, because there is no good model that you can use. So it's just safety study. He did trial in human. Unfortunately, he died in the middle of the trial, but the results are, I would say, reasonably good. Namely, there is some effect there. Not good enough that someone will pick it up, but quite good. So the idea was to try to improve from this point. So again, we take the approach that I showed you before, starting with the performance, what we want to achieve, then look for the properties, structure and processing, and everything done with relevance to tribology. And the question is, so liposome you already know, I can skip it, but actually in this case, for reasons that I explain later, we did not use the small liposome like in the doxil, but we use rather large liposome, and that's for biological reasons that I'll tell you in a minute. So liposomes are not toxic, we already talked about it, and they are biocompatible. We also prove it in animals now, in rabbits and in other animals, in rats, that actually this system are pretty clean from the toxicology point of view. The question is how to evaluate. As I said, the in vivo methods are usually did with extreme cases of that you have a severe pain, that you have a lot of inflammation, and in most of the cases, this is not the case. In most of the people, this is not the case. We want to come much earlier than this. So the question how we can evaluate it. And we found that the in vivo experiments in this case are not going to be informative enough, and also they take a very long time, and the results are questionable. And that's agreed by many other people. And the other things that we have to deal with, okay, how we are going to characterize the liposome, and can we find some kind of a marker? What I said again is in vitro and vivo correlation, IVC, that this marker in the physical properties will tell us, okay, this is a good preparation and this is not good preparation. How we can select the right lipid. And there are a lot of parameters we have to look for. It's the liposome size, lamellarity. This is the basic, which even didn't mention here, compressibility, because we're dealing with a lipid. You know, the lipid is much more compressible than water, actually. It's amazing in the scale of compressibility. So what we want is high compressibility, low compressibility, how to measure it, what kind of phase we need. Is it be the same LO phase like in doxil or another phase? What kind of, the lipid can be hydrated or unhydrated, what kind of things will be the best for us? So this is the question we ask. We also have to find a model that can reflect the biological situation, and we can get answer if we really lower or improve on both on the wear, reduce the wear, and also reduce the friction. And we build a system for it. So here, when we deal with the lipid phase, if you remember well, with the doxil, we look for the LO phase. We found here that the LO phase doesn't work well. I don't have time to go into detail, but the main reason is that these lipids are packed too tight, and also the other reason is that they are not hydrated enough, and I'll go into it later.